Hi, my name is Jackie Gordon, and the title of my intervention proposal is Physical Activity to Prevent Adenomatous Polyps. Between 2007 and 2011, incidence rates in the U.S. declined by 4.3% per year among adults aged 50 years and older with colorectal cancer. For the past 20 years, the mortality declined by 2.5% per year. However, it's the third most common cancer in men and women in the U.S. and the second leading cause of cancer death in the U.S. This comes with a cost. Medicare program costs have been estimated to increase to $14.02 billion in 2020 from $7.49 billion in 2000. Projected costs in 2020 and the initial continuing and last year of life in treating colorectal cancer are $5.19, $3.57, and $5.27 billion respectively. Colon cancer screening is expensive. However, adults aged 50 years or more result in an average cost-effectiveness ratio ranging from $10,000 to $30,000 per life year saved compared to no screening at all. The population that is overwhelmingly affected with colorectal cancer are those aged 50 and older. They are 24.09 times more likely to be diagnosed with colorectal cancer than those who are less than 50. Lifestyle modification, medications such as aspirin, and screening are all related to preventing colon cancer. Screening recommendations are high sensitivity fecal occult blood testing, sigmoidoscopy, or colonoscopy beginning at age 50 years and continuing until age 75 years. Those at high risk for developing colorectal cancer should be screened at a younger age and may need to be tested more frequently. There are several risk factors, most of which are non-modifiable for colorectal cancer. We've already discussed age. Some genetic syndromes are risk factors. Inflammatory bowel disease. Crohn's disease is associated with a relative risk for colorectal cancer of 2.6, and ulcerative colitis is associated with a relative risk of 2.8. Personal or family history of colon cancer or colon polyps is also associated with an increased risk. Those with a first-degree relative carry a relative risk of 2.24 for colorectal cancer. Those with greater than one first-degree relative, that relative risk almost doubles to 3.97, and those with parents have a relative risk of 2.07. Modifiable risk factors, including obesity, consumption of red meat and processed meats, and smoking, are associated with a relative risk of colorectal cancer of 1.2. Alcohol consumption and a sedentary lifestyle are also associated with colorectal cancer. However, there are some things that can decrease the risk. Physical activity has been shown to decrease the risk, calcium and milk consumption, and then finally screening. Screening for colorectal cancer has drastically increased early detection of colon polyps that could possibly lead to cancer. A large intervention study enrolling over 150,000 men and women aged 55 to 74 years of age randomized to usual care or flexible sigmoidoscopy with repeat screening at 3 or 5 years showed a 21% reduction in incidence of colorectal cancer for those in the screening group. The intervention of interest to my study is physical activity. The mechanism in which physical activity decreases the risk for colorectal cancer is unknown. Some of the mechanisms are listed here: decreased GI transit time, decreased ratio of prostaglandins, lower bile acid secretion or enhanced metabolism, and decreased circulating insulin and glucose are all things that are all mechanisms in which physical activity could possibly decrease the risk of colon cancer. There have been intervention studies performed to evaluate the physical activity intervention on an outcome associated with colorectal cancer. There are a few randomized controlled trials that have been performed to look at the association, and I could not find any that looked at incidence of colorectal cancer. I found studies that looked at biomarkers that increase your risk for colorectal cancer. Irwin and colleagues in 2003 enrolled 173 overweight, sedentary, postmenopausal women, and the intervention was moderate intensity aerobic exercise, 45 minutes per day, 5 days a week for 12 months. They found that estradiol levels significantly decreased in exercisers who lost 0.5% to 2% of body fat, and exercisers had a 4% decrease in insulin concentrations at 12 months, and non-exercisers had a 12% increase in insulin concentrations. Limitations of this study is that exercise was performed at home and it was self-reported in an activity log compared with exercise performed at the facility, which was both self-reported and observed by the exercise trainer. Another physical activity intervention study by McTiernan and colleagues in 2006 looked at 100 women and 102 men who were healthy but led sedentary lifestyles and had had a colonoscopy within the previous 3 years, and they were 40 to 75 years old. The intervention was a 12-month exercise intervention of moderate to vigorous aerobic exercise, 60 minutes per day, 6 days a week. They were interested in looking at the makeup of the normal colon mucosa. And what they found was that there were significant decreases in colon crypt cell proliferation indices in men who exercised a mean of greater than 250 minutes per week. Again, the study did not look at a colorectal cancer endpoint, but a biomarker for colorectal cancer. Limitations to this study is that exercise was done at home and self-reported in a daily activity log, compared with exercise done at a facility, which was also self-reported in the log. So the objective of my study is to determine whether a physical activity intervention decreases the recurrence of an adenomatous polyps in those who have had a previous adenomatous polyps age 50 to 75. I hypothesized that a physical activity intervention of moderate to vigorous aerobic exercise, 60 minutes per day, 6 days a week, will decrease the recurrence rate of new adenomatous polyps in those who have had a previous adenomatous polyp who are 50 to 75 years old. My study design is a randomized controlled trial of men and women aged 50 to 75 residing in Pennsylvania. Participants will be included if they're 50 to 75, have had a documented adenoma removal histologically confirmed within the previous 6 months. Exclusion criteria include an invasive carcinoma in the colonoscopy that was performed in the previous 6 months, failure to comply with the fully examined colon during that colonoscopy, incomplete removal of polyps during that colonoscopy, inadequate bowel preparation for that colonoscopy, or a history of familial polyposis or other polyposis syndromes, histologically confirmed inflammatory bowel disease, history of large bowel resection, a current life-limiting condition, current participation in a study that would interfere with this study, if they have a current exercise regimen equivalent to the physical exercise intervention in this study, and finally, they will be excluded if they're unable or unwilling to sign the informed consent. Potential participants with documented adenoma removal will be identified by collaborating with endoscopists in a large health system in Pennsylvania. The intervention for this study is moderate to vigorous exercise, 60 minutes per day, 6 days per week. Moderate exercise will be defined as 50 to 70% of maximum heart rate, and vigorous will be defined as 70 to 85% of maximum heart rate. Each participant who is enrolled into the intervention group will be seen by an exercise physiologist in an exercise physiologist laboratory. They will get education regarding the 60-minute moderate to vigorous exercise intervention, and they will be provided personal moderate to vigorous heart rate goals by the exercise physiologist at that time. They will also be provided with a fitness tracker with heart rate monitoring capability and Wi-Fi capability so that it can be transmitted to the study coordinators. They will be seen by the exercise physiologist subsequently every 2 weeks for the trial duration. It is appropriate that endpoints and disease outcome measurements are selected carefully for this study. Per the CDC, current colorectal cancer incidence rates in Pennsylvania are 42.7 to 48.9 per 100,000. This translates to 0.04% or 0.05% incident of colorectal cancer. This makes an extremely large sample size. This would have substantial costs and a long study period to use colorectal cancer as an endpoint. So a surrogate endpoint must be chosen. Biochemical markers were not chosen for this study because there is still research to be done to decide what exact biochemical markers are associated with colorectal cancer. The adenoma carcinoma sequence is much more clear. Most cancers come from adenomas, and adenoma is by and large a necessary precursor lesion on the pathway to malignant colorectal cancer, and colorectal adenoma recurrence is much greater than the incidence rate for colorectal cancer. So this enables this trial to be smaller and shorter. And another positive of using colorectal adenoma is that adenoma surveillance is a part of standard clinical practice. So the study design. The sample size will be about 2,000 participants, 1,000 in each group. This is based upon a 90% power, a 20% reduction in annual recurrence rate in the intervention group with the physical exercise, a one-tailed significant test using the binomial distribution at a 5% alpha level, equal-sized treatment groups, and an effect of the exercise intervention on polyp recurrence will operate 1 year from the start of the intervention. A 10% loss to follow-up over the course of the study has been assumed, and the sample size projections are based on a 3-year period of follow-up between the year 1 colonoscopy and the year 4 colonoscopy. The reasoning for this is that at least 10 to 15% of polyps are expected to be missed at baseline. At year 1, it is established that the bowel is effectively cleared at polyps during the study, so that the 3-year interval will more accurately reflect new recurrent polyps without contamination from previous polyps missed at baseline. Patients who are eligible will be randomized to the intervention group or the control group. The intervention group will receive the intervention and continue the intervention for the full 4 years during the study period. They will have scheduled meetings with the exercise physiologist every 2 weeks. They will have a colonoscopy at year 1, as the control group will. And at year 2 and year 3, they will check in with the study coordinators. And then at year 4, they will have their final colonoscopy. Recurrent adenoma is the endpoint for this study. Adenoma found on colonoscopy after baseline colonoscopy. Secondary endpoints include number, size, location, and histology. The pathologic review for these adenomas will be done by local pathologists evaluating all polypoid lesions removed from participants. Coordinators will enter findings into a standardized trial endoscopy data collection tool, and then 2 central pathologists from the study will review all polyp material. Whole polypectomy specimens versus cold biopsies will be used due to the findings from the Norwegian colorectal cancer prevention trials, in which they found that cold biopsy diagnosis underestimated histopathological diagnosis in about 10% of colorectal adenomas. Using whole polypectomy specimen will make recurrent adenoma identification a more valid test. Anticipated outcomes of this study is that at year 4, the intervention group will have decreased percentages of adenomas, recurrent adenomas found, and that this will be statistically significant from the control group. There are strengths and limitations with this study. A strength of this study is that it is a randomized controlled trial. It will show a causal relationship between physical activity and adenoma formation, whereas most current evidence is observational. However, the study will be costly. It involves fitness trackers and exercise physiologists, and 2,000 study participants to be seen, or 1,000 study participants to be seen every 2 weeks. There is a potential loss to follow-up. It's a 4-year-long study. Not all adenomas progress to cancer, so this really isn't a real colorectal cancer endpoint study. However, those studies would be much more costly. It's perhaps inappropriate to start primary prevention using physical activity at age 50. Perhaps the association is because physical activity was started earlier in life. And it's possible that 4 years is not enough time to see changes and an impact of physical activity on adenoma formation. And then finally, the results will have limited generalizability as the study was only conducted in Pennsylvania. Here are my references. And thank you for listening, and I look forward to your comments on Angel.